Good afternoon, everyone just attending us. We'll just give this a couple of minutes and then we'll get started. We'll just let everyone join us. Just give a couple of seconds and then we will get started with everyone. Hopefully you can all hear me okay. Right, I think we can get started, and anyone jumping in hopefully can catch this, and also there will be a recording, of course. But first of all, just good afternoon to everyone and welcome again to the latest instalment of VetCT's 12-minute take-home webinars. It's great to see so many of you here again. If you haven't had a chance to try the VetCT app as yet, please remember you can register and get a free trial of the app. So download this from the App Store and Google Play, or you can contact me directly. You'll see my email address on the screen, david.moffat@vet-ct.com or sales@vet-ct.com. There is no commitment or cost during the free trial period, and you'll gain 24/7 access to a team of friendly specialists across all disciplines. Choose to communicate with the team via instant callback, text chat, book an appointment at a time that suits you, or even ask for a written report while learning on each case. And anyone in the UK, you'll also get the added benefit of real-time CPD. So on to today's 12-minute webinar. As a reminder, this session itself is being recorded and there will be an opportunity to ask a few questions at the end. So can we ask, if you do have any questions, if you can put it into the Q&A section of the screen on the webinar rather than the chat, and then we'll go through those at the end, and we'll get through as many as we can in the time and come back to you with any others afterwards. If we can just skip to the next slide, I just wanted to introduce you to our oncology team before we get started. So you'll see on the screen there, we've got Dr. Charlotte Johnston, Chiara Leo, Dr. David Killick, Dr. Juan Carlos Serra, Dr. Cassia Puzica, Dr. Penny Thomas, Dr. Shay Bracker, and Dr. Sophia Carvalho, who is going to be running today's session. So these are the friendly oncology team that you get to speak to through our app. So Sophia, I'm going to pass over to you now to introduce your session for today.
Thank you, David. That's great.
Thank you.
And thank you, everybody, for being here with us today. Today I'll be talking to you about canine mast cell tumors. Are they all the same? I chose this topic to discuss with you as one of the options for you to vote, because this is such a common disease and a disease that we get lots of inquiries and referrals about in practice. And it's true that not all canine mast cell tumors behave the same. And I think it's important to bring up some topics to discuss today. So if we look at these two pictures here, we can wonder if a mast cell tumor in the muzzle of a pug is the same thing that a mast cell tumor in the limb of a Shar Pei. And we can look at these pictures and already say that no, they are very, very different. On the picture on the left, you have a very well demarcated pink superficial nodule, while in the picture on the right, in the limb of the Shar Pei, you have a huge non-ulcerated lesion, lots of satellite lesions, peritumoral edema, etc. So you can already see that mast cell tumors are one of these diseases that behaves so differently and has such a wide range of clinical appearances. They are by far the most common tumor in the skin of the dogs, and they account between 16 and 21% of all the cutaneous tumors. And here you can see a picture of the typical cytological appearance of these cells, round cells, quite granulated, in this case, quite a monomorphic appearance. There are many prognostic factors that exist that help us to predict the biological behavior and the clinical outcome of dogs with mast cell tumors. And so it's really important for us to be aware of all of these, if not some of these prognostic factors, because these are the ones that are going to help us deciding what should we do to approach a patient diagnosed with a mast cell tumor? How much staging should we do? How much treatment should we do? What is the type of treatment? And ultimately, what is the outcome of our patient? We need to remember that there is no one factor that is entirely predictive of biological behavior, and we should take all the prognostic indicators into consideration when we are trying to decide what to do. So this is a table that I took from the book of Whitrow Small Animal Oncology, and you can see here that there are many prognostic factors that have been associated with the prognosis of mast cell tumors. And we are going to go through some of them, the most important ones that we use in the practice to help us making these decisions. So the grade, the histological grade is by far the most consistent and reliable prognostic factor for this disease. Although it's true that will not predict the behavior of every tumor, so we always need to keep in mind all these other prognostic factors and try to incorporate those in our treatment decision making. You may be aware of these two histological grading systems that exist. When you are reading your histopathology report, it usually comes up with a Patnick grading system that divides mast cell tumors into three categories: grade 1, grade 2, and grade 3, and the cupel grading system that divides them in two grading categories, the low and the high grade tumors. It's true that nowadays we don't have a really well-defined cytological grading system for mast cells, but a recent study has shown that there are some cytological characteristics associated with biological behavior as well. So you see the two figures here. On the left, you have large round cells that are poorly granulated with some degree of anisocytosis, while on the picture on the right, you have the typical round mast cells, quite monomorphic appearance and quite well granulated. So cytologically, we can use some criteria to help us predicting biological behavior, such as degree of the granularity, degree of nuclear pleomorphism, anisocytosis, and presence of binucleated cells, for example. So a well-differentiated mast cell tumor will look quite small, quite well demarcated, will have quite a slow-growing history. Sometimes these tumors may have been present for several months, even years, and are usually solitary. Sometimes they even appear like non-neoplastic diseases. For example, this picture here, you almost would think this would be kind of a wart-like lesion and not a neoplastic, rather than a quite well-differentiated mast cell tumor, like this picture on the right. It has a history of rapidly growing. They look ulcerated. It can achieve quite a large size, and they can be associated with peritumoral edema and inflammation, usually in association with the release of histamine, heparin, and other vasoactive amines from the mast cell granules. Sometimes you can have some satellite nodules around the tumor. So you can see that they can behave quite differently. In the histological grade, as I said, it's the most consistent prognostic factor that we have. We know that the majority, 80 to 90% of dogs with well-differentiated mast cell tumors, and approximately 75% of dogs with intermediate grade mast cell tumors can experience quite long-term survival times after complete excision. That's not the same for dogs with undifferentiated tumors, where the metastatic rate can go up to 96% of the cases. There are other proliferation markers that are quite helpful to help predicting prognosis. Mitotic index is one of them, and is one that is readily available in all your histopathology reports. So you should always identify the mitotic index and try to see what it is. Older study has suggested that a mitotic index of less than 5 is associated with a favorable prognosis of around 80 months when the tumors are removed, rather than a prognosis of only 3 months if this mitotic index is greater than 5, sorry. So the mitotic index is readily available, doesn't require any special stainings, but there are other proliferation markers out there that can be quite helpful as well. And I'm sure you've heard about the Ki-67 especially, but we have others such as AGNOR and PCNA. So you may have noticed in some of your histology reports, the diagnosis comes back as low-grade/intermediate grade mast cell tumor. If you would like to request a Ki-67, please get in touch with the lab, and you are always a little bit, should I request it? Should I not? Is it going to help us deciding what to do? Should I be using the client's money for it? I get lots of inquiries regarding Ki-67. And the truth is that many times it's really helpful, and it will help us deciding if we want to do further staging or further treatment, but sometimes it can be bringing some confusion to the clinical case. So I just wanted to bring a couple of studies to you regarding Ki67. There was this study with 120 dogs with solitary excised cutaneous mast cell tumors, where it's been shown that a higher mean number of Ki67 positive cells in 1,000 tumor cells was significantly associated with higher rates of dying from a mast cell tumor. And this was specifically true for dogs with grade 2 mast cell tumors, where the number of Ki67 positive cells was greater than 93 versus less than 93. You may be more familiarized with the number in this study, where a cutoff point of Ki67 score of 1.8 was significantly predictor of survival for dogs with grade 2 mast cell tumors. And we can see in this graph here on the left, the Kaplan-Meier survival plot has the, and that was quite obvious. So the dogs with grade 2 mast cell tumors and Ki67 scores less than 1.8 had estimated survival times at 1, 2, and 3 years post-diagnosis of 92, 86, and 77%. So quite nice survival rates, but that was not the same in these dogs with grade 2 mast cell tumors if the Ki67 score was higher than 1.8. In those cases, the estimated survivals at 1, 2, and 3 years post-diagnosis dropped to 43, 21, and 21% respectively. There are many other proliferation markers available, as I said, and they have shown that these proliferation markers are associated with the tumor grade, so higher scores are associated with higher histological grade. The Sickid gene is quite a helpful one as well. We know that 20 to 40% of canine mast cell tumors have a mutation in the Sickid gene, and this renders the KIT protein to be constitutively active, and this is going to promote cell proliferation and cell survival. So the presence of a Sickid activating mutation is associated with higher rates of local tumor recurrence, of metastasis, and of death as well. So that's a well-known prognostic factor as well. We know that having a Sickid mutation will give us a higher likelihood of responding to certain drugs, such as tyrosine kinase inhibitors, such as Palladia and Mazivet. So sometimes it's good to know that they do have this constitutively active mutation, because that's going to help us deciding what is the most appropriate treatment protocol for our patient. Tumor location is another prognostic factor. Certain locations are associated with more aggressive tumors, such as tumors in the preputial or inguinal region, subungual or oral cavity, perineal or mucocutaneous regions. Furthermore, we know that certain locations, such as in the muzzle, are associated with a higher metastatic rate. So tumors in the muzzle, mast cell tumors in the muzzle of the dogs, associated with metastatic rate of approximately 60%. This metastatic rate is higher than tumors in other locations, although if they are adequately treated with a good local control and a combination of different treatment modalities, survival time can still be quite good. The clinical stage is definitely also predictive of outcome, although the effect of lymph node metastasis is controversial. Some studies have shown that lymph node metastasis can be a negative prognostic factor, while others have shown that in case of intermediate grade mast cell tumors, if you have lymph node metastasis but you treated them adequately with a good local control and possibly a course of adjuvant chemotherapy, the prognosis can still be quite good. That's definitely not the case if you are dealing with a poorly differentiated tumor, where the presence of metastatic disease in the lymph node will be prognostic for survival, medium survival times of around 200 days if you have lymph node metastasis, versus medium survival times of about 500 days if you have no lymph node metastasis. So it's really a combination of factors that we have to be considering. There's many others to consider, but breed I wanted to discuss with you. It seems that boxers, pugs, and dogs with bulldog descendants seem to be associated with a better prognosis. It could be because these dogs are so common in practice and we see them so often diagnosed with mast cell tumors, but the study did show this better prognosis in these breeds, versus Shar Pei, Chinese Shar Pei is associated with a worse prognosis. The rate of the growth and the presence of systemic signs are also associated with a negative prognostic outcome. And the systemic signs are often associated with the release of all the histamines, heparin, and all these active amines that are released by the mast cell granules. So when the time comes to treat, we really need to think about all the prognostic factors to help us deciding, should we cut the tumor? What is the dose of surgery we should be thinking about? Is it okay if we use a marginal excision, or should we be thinking about a wide surgical excision or a compartmental excision? Is adjuvant chemotherapy going to be recommended? If so, what is the drug? What is the protocol? We do have many treatment options out there at nowadays. Radiation therapy can work quite well as well. Is it going to be necessary? And the owners often ask, is the tumor going to recur? Am I going to do all of that? And is the tumor going to recur? So when we're thinking about treatment decisions, we really need to think that our treatment decisions are going to be predicted by the presence or absence of all the negative prognostic factors that we have available for the given patient. And the prognosis of that patient will be dependent on all of these prognostic factors. So just some examples here. Most low-grade mast cell tumors can be adequately treated with surgery alone, provided the site is amenable to adequate surgical excision. And this is often associated with low recurrence rates and low metastatic rates. And sometimes even a marginal excision may be okay. We know that 10 to 30% of surgically and completely removed mast cell tumors will recur, but the other 70% will not. So this could be the cases where if we don't have many other prognostic factors to help us deciding, should we be doing something else? Should we do active surveillance? This could be the cases where we can think about requesting certain proliferation markers to help us as well. For high-grade tumors, we know that median survival times historically reported are quite low, of around 3 months' time, but that's not true for all cases with high-grade tumors. And if we have a high-grade tumor, we should definitely, and other negative prognostic factors, such as the one that we commented today, we should be thinking about multimodal therapies. We know that there are many treatment options available nowadays, and the results have greatly improved over the years. So these 3 months time historically reported, it's not going to be the case for every dog with a high-grade or high-risk mast cell tumor. So just some take-home messages. Cutaneous mast cell tumors are quite a heterogeneous group of diseases, and it's important to think about treating our patient individually. And that's true for the majority of cases with cancer, because they can behave in such a different way. So it's important that we evaluate all the prognostic factors that our patient is showing us. And if we don't have all of them, to think about requesting them to help us deciding how much staging, how much treatment should we be thinking about, and ultimately what is the outcome for our patient. So I hope this talk hasn't left you with more questions than answers and hasn't confused you. And I'll be happy. Thank you so much for being here and listening today. I'll be happy to answer any questions that you may have now. Let's just have a look here. So we have a question from Kate Murphy. What are your thoughts on the new treatment options, example, Stelfonte? When would you use it over standard options? Have you seen significant tissue defects when it is used? So actually, I haven't used it myself personally. I've read about it, and I think the idea of Stelfonte is really to cause like a necrosis and a tissue reaction of the tumor, which can be quite severe in some cases. I've seen some pictures and discussed some cases with some colleagues of mine. So I think surgery is still preferred option. If surgery is indicated, surgery is definitely still the preferred option. I think the Stelfonte will be indicated for less aggressive tumors. We wouldn't be thinking about Stelfonte if we have a big mast cell tumor with lots of peritumoral edema. So yes, I think significant tissue defects can occur with the Stelfonte, but I don't have a personal experience myself, unfortunately. Now, do you think, Kate Murphy, another question, do we think liver and spleen should be aspirated regardless if they look normal on ultrasound? Yes, I think that depends on the case as well. I don't think we should stage all the patients straightforward. Not all the patients will definitely need liver and splenic aspirates. For example, that photo that we saw, the wart-like lesion in a dog has been there for years, and it's been stable in size. I think definitely need to achieve the diagnosis. And I think we should always sample the regional lymph node, and I would always aspirate the regional lymph node, even if this is of normal size and normal appearance. But if this lymph node is negative, I wouldn't necessarily be then aspirating liver and spleen for all of the cases. If we are dealing with a more aggressive mast cell tumor, definitely then, regardless of their appearance on ultrasound, we would definitely aspirate it. So if I would have negative prognostic factors, some of the ones that we've discussed, or if I'm suspecting a higher risk mast cell tumor, then yes, and I would aspirate regardless of abdominal ultrasound. But I wouldn't routinely aspirate every liver and spleen for every case of mast cell tumor, because we know that the metastatic rate systemically for liver and spleen is actually quite low, especially if we don't have metastasis in the regional lymph node. Roger Powell, do you think the compositional cytograding schemes should be used to guide staging investigations required for that mast cell in conjunction with growth, etc.? Yes, I think, I mean, I've been really looking forward to having a cytological grading scheme because we don't routinely perform biopsies as part of diagnosis, at least. I mean, we know cytology is such a great test, and usually we go with cytology to start with. It's very uncommon for us to have the grading before we even start the treatment as well. So yes, I would love to start using cytologically grading more often and try to use that to decide if we should be staging further or not. And yes, I agree with you, should always combine cytological grading and even histological grading with all the other prognostic factors for the patient. But yes, I think using cytology would really make sense in this disease. Well, in every disease, but it's great that we do have something now to help us. Lillian Mathay, do you recommend FNA? Do you mean FNA of the primary tumor? Don't know if you recommend, don't know if you're still live, you can type further. If you mean FNA of the primary tumor or of the lymph node, I think as a first step, as I was answering to Roger, definitely I would always start with FNA of the primary tumor. I don't know if you are meaning if you have like a high-grade tumor and you're worried about mast cell degranulation. If that's the case, it definitely would favor FNA versus biopsy, for example, and there's some measures we can use to try to reduce FNA of the tumor. Okay, thank you for that. Yes, always FNA of the tumor as a first step for diagnosis, also FNA of the tumor. And as we're talking now, there's some proposed cytological grading out there, which is great, so that will give us more information about cell features and try to predict histological grading as well. We do, I mean, if you have the typical tiny, well-differentiated mast cell tumor, the risks of FNA are very, very, very small. If you have a very angry mast cell tumor, lots of peritoneal edema and reaction, you do have risk of mast cell degranulation, but you can pre-treat with some antihistaminics, you can pre-treat with some corticosteroids as well. So yes, I would always do FNA, and then I would always sample the regional lymph node if I can. I hope that's okay. We have showered Lawani. Before surgery, do we need to give prednisone or antihistaminics, and what is the dose? Yes, I think that goes along with the other question. So if you have quite an angry mast cell tumor, yes, it may be a good idea to give some antihistaminics. You can even start the antihistaminics a few days before, and you have to think about using antihistaminics, anti-H1 and anti-H2, for example, the chlorphenamine or famotidine/ranitidine. So yes, I would use those. Regarding prednisolone, if you're going to do surgery afterwards, wouldn't be lucky to start quite a high dose. Maybe you can think about giving like anti-inflammatory dose, 0.5 mg/kg once a day, but it will definitely depend on how angry is your mast cell tumor. In some cases, it may be indicated to go higher if you are really worried about mast cell degranulation. Francesca, how can you reach certain lymph nodes like medial iliac or retropharyngeal, and even some superficial ones like inguinal, if not properly enlarged? Yeah, that's a good question. And many times you do need imaging guidance, especially for your medial iliacs. We do that quite a lot for the inguinal mast cell tumors or the perianal. We see quite a lot of mast cell tumors in that region. So yes, image guided, ultrasound guided. And it's incredible. Mast cell tumors, really, they are the systemic disease. I've seen lymph nodes quite tiny where the radiologists are like, I don't want to sample those. And they're just 4 or 5 millimeters in size. And then we sample them, and yes, cytology comes back positive. So I would always try to sample the lymph nodes even when they look normal. But I agree with you. Sometimes it's quite challenging. Even the superficial inguinals, sometimes in all the mammary tissue and also cutaneous tissue, they're really difficult to sample. But yeah, ultrasound would be the way to go, and the same thing with the retropharyngeals. I think that's it for questions. If nobody has any other questions. No? So thank you all for being here today.
Thanks, Sophia. There we go. That's it. Thanks, Sophia. Thank you for a good session. Thank you for everyone for joining, and also thank you for the really good questions there at the end. I also noticed some people mentioning how they use the service as well and giving feedback, so that's really beneficial to see as well. We hope that you found it interesting. Please do keep an eye out for any future sessions. We'll be running another one at a slightly later, well, definitely a later time next week at 7 p.m. In the UK. That's next Wednesday. That's with Dr. Copper Aiken Palmer. So please register for that if you've not already done so. The recording of this session will be available through our website and also YouTube shortly, probably from later on today or tomorrow, if you want to have a look back over. And finally, don't forget to download the app and have a free trial if you want to have a go. I think that's it. Thank you, everyone.
Thank you. Take care.
Thanks, Sophia.
Very nice.